Hi, my name is Premal Lulla. I'm one of the transplant physicians at the Baylor College of Medicine, and we have a clinical trial where we have treated patients with multiple myeloma with a novel immunotherapy approach. In this treatment, we infuse T cells that came from the patient, but the difference is we don't engineer these T cells to go after the myeloma. Instead, we expand them ex vivo to react against antigens that are commonly expressed by myeloma cells. Indeed, our products are specific for multiple myeloma-specific antigens, and the 5 antigens targeted are PRAME, SSX2, MAGE-A4, NY-ESO-1, Survivin, and these products are polyclonal. They can simultaneously target these multiple antigens in vitro, and we've demonstrated by functional analysis that they are highly specific for, more often than not, multiple antigens. So far we've manufactured 20 T-cell lines from patients with myeloma, and the manufacture has been successful 100% of the time. The T-cell products that were manufactured have now been infused to 20 patients as well. And the way we enroll patients is we put patients in a group that are ineligible for transplant or who had had a transplant more than 90 days prior to receiving T-cells. That's the group A. And we had a group B, which are patients who had recently undergone a transplant. The T-cells that we infused were infused without any prior lymphodepleting chemotherapy. And then once we infused these T cells, we saw that they expanded at both the clonal level as well as by functional analysis post-infusion. And what we're going to demonstrate at this ASH's abstract is the expansions higher for those patients who receive T cells with active relapse myeloma compared to those patients who were in remission when we infused the T cells. So how did these patients do? Well, out of the 20 patients we've infused, we infused 12 patients who had active myeloma at the time of infusion and 8 patients who were in remission. And out of those 12 patients that we infused with active myeloma, only 4 have gone on to relapse at 12 months post T-cell infusion. And indeed, at week 6, we saw a couple of responders, and then by month 12, we had 2 additional, so 4 total objective responses on the study, while the rest remained in ongoing stable disease. Amongst those patients who were in remission at the time of T-cell infusion, all of them except for 1 patient have remained in a remission at month 12 post T-cell infusion. So the good news was we saw no cytokine release syndrome or neurotoxicity, and we actually didn't see any evidence of off-target effects either, which is a concern with therapies that target self-antigens. So good question, and that is a point of distinction with gene-modified therapies where you have supraphysiological activation of these T cells. These T cells work at a more physiological level, and thus, therefore, I think we didn't see any side effects. So that's a summary of our clinical data and our clinical outcomes. We're enrolling at the highest dose level right now, which is dose level 3, and we anticipate completion of this trial very soon.
How about the side effects?